My name is Dr. Ed Shahady, and we're here at the Cardiometabolic Risk Summit in Las Vegas, and with me is Dr. Saundra Jain.
Hi, Dr. Shahady.
Nice to see you again.
You as well.
And she's going to be talking about diabetes distress, and she's a professor at the University of Texas in the School of Nursing, and really a pleasure to have you here again. So you're going to be talking about diabetes distress, and that's an interesting topic. I don't think a whole lot of people understand it and realize it. So tell me a little bit about it. What is it?
Absolutely. I had the pleasure of being here last year, and what I love about this conference is I had the opportunity to speak to attendees, not only as a practicing clinician, but also as a type 1 diabetic. So it brings, I believe, a different perspective to the conversation. And the takeaway about diabetes distress is it's about twice as prevalent in practice as major depression is. The error that we're making as clinicians, understandably so, is we're identifying what is actually diabetes distress as major depression, and then following a course of treatment as if the patient has a major depressive disorder, and then outcomes are less than what we would hope for. So diabetes distress, because it does look like major depression, can oftentimes be under-recognized, difficult to identify, and then also difficult to sort of tweeze the two disorders apart. So the real goal of the session is to talk with attendees, introduce them to the diabetes distress scale, 2-question version and a 17-question version, to really give us the skills and the tools we need in practice to know, is this diabetes distress, which would be subclinical depression, or is it truly major depression?
And I guess we make the mistake as clinician, we treat them with antidepressants, and that's not going to help diabetes distress, or is it?
Well, I mean, I guess part of that would be diabetes distress, looking at it in terms of duration, the level of impairment, because then that's going to push us over into more clinical depression. The challenge is whether it's diabetes distress or whether it is in fact a comorbid psychiatric condition, major depression, an anxiety disorder, those unidentified then become barriers. They become hurdles to us achieving good outcomes. And last year, and I'm sure this year will be the same, the challenge is that we're all drawn to this profession to help people. We want people to get better, to stay better. But if we as clinicians do not initiate the conversation to find out if you're my patient, how are you doing emotionally? Where are you with this new diagnosis? Maybe you've had it 5 years, maybe it's not new and you're still stuck. When those things are unidentified and not discussed, outcomes suffer.
And you're recommending the, their 2-question one, and then I guess if that's positive and they've got numbers and everything, you go to the 17. What patients should I be thinking about? Those that aren't in control? Is that who I should be using it on?
Such a good question. American Diabetes Association did a really nice job of giving us a template that basically says this: psychosocial assessment is ongoing. And ongoing, our touch points are simple things like, what do you expect from your treatment? What are your attitudes about this illness or this disease? How can we help you? What are your resources, financially, socially, access to care? Each time we see these patients, have that conversation. And then here's the red flag. When we see that patient self-care is suffering, it's the red flag that slaps us in the face as clinicians that says, now we must screen. We must proactively screen for major depression, diabetes distress, potential eating disorders, maybe in certain populations, and also cognitive impairment. So I think ADA has really helped us because it's given us that outline. So if we're going to screen, we see some red flags, you're not taking care of yourself. I guess as clinicians, we would call that non-adherence. We would then go in with diabetes distress scale 2 as 2 simple questions, and it's so simple. In the last month, how bothered have you been by these 2 things? Feeling overwhelmed by the condition of diabetes and feeling like you're not following the treatment plan well.
And to look at people that aren't, because if I got somebody that's well controlled, I'm probably not going to get a lot of yield for that. So it makes sense. Now, as I understand the diabetes distress 17 questions really helps them divide it up into, I think, 4 parameters. Do you want to tell me what they are and what's the most common?
Absolutely. So the definition of diabetes distress, the scale was really developed in the world of type 2 diabetes. So the 4 buckets you referenced, they begin with emotional burden, access to care, worries about that, disease management, and then a really interesting one that if we don't really ask about, we miss. And that is diabetes-related conflict with family members. And this one always amazes me, the conflict that patients have with healthcare providers.
Yes.
You may not be aware of it because we're very quiet about it. So as you're giving me directions about how I might take better care of myself, if I'm stuck in diabetes distress or any other psychiatric condition, I may very well be listening and smiling, but thinking to myself, I'm not going to do that. Don't care what you tell me, you will not convince me because I'm stuck.
And I guess it's regimen-related distress that's number 1. With that, and that's I'm having trouble following my diet, taking my insulin correctly, exercising. So those are the things, I guess, that are highest on the distress scale. Is that correct?
Absolutely. The disease management.
Yes, yes.
And you made such a good point because with the diabetes distress scale 17, I might use it first line over 2 questions. In 2 situations. A new patient comes to my practice and I don't know very much about you. So I want as many questions as I can get. I want a score for each of those subscales. Or maybe you're a patient that's been referred in, previously treated elsewhere. I want a baseline. And then my touch points. Maybe I see you every 3 months. Then I'm going to go back to DD2 if you're not taking care of yourself. That's the red flag that causes me to pull that out of the...
Let me follow up with the point about that some of the questions are about the provider and the provider creating distress. Well, what I find interesting, if I give the 17 question to my patient, they never say they're unhappy with me. So I sometimes ask my diabetes educator or my medical assistant to do it because I think they're going to be more truthful. So do you recommend that?
I think that's a great way to do it. Because again, I think traditionally, even for myself, sometimes with my endocrinologist, I might not be as willing to say, I don't really agree with you, or I don't like that, or based on history, I know I'm not going to do it. There's an interesting study I read in preparation for the talk at this conference, and it looked at how willing we as patients are to talk to you as providers. And it said that 1/3 of us who up front said, oh, we have good relationships with our healthcare provider. Almost 1/3 were still reluctant to talk about problems like, I'm having trouble with my regimen. I don't feel like I'm keeping up with the plan. I'm really struggling. So I think it goes back to that, what we see as providers isn't always what we get. I may look really compliant and really happy. So I think if we can have people in our offices more than just us asking, gauging the temperature of their emotional well-being, we might be able to tap into what leads to these roadblocks, these impediments to good outcomes.
Let me offer a thought. And compassion fatigue, I think a lot of physicians have it with their patients that aren't doing well. You know, I take care better of myself. You know, I'm more interested in your health, So they're really angry. Do you think doing the diabetes distress scale is going to help them understand better what the patient's going through and have more compassion for them? That's just a thought on my part. What do you think?
I couldn't agree with you more. Because the relationship is two-way. And if we're not, as clinicians, really present, knowing what I as a patient might bring to that experience, how could we possibly understand what's happening? But if in doing those questions, engaging and knowing emotionally where I am, all of a sudden the conversation changes. It changes. All of a sudden I'm no longer non-compliant, a problem for my provider.
Well, you used the word adherent before, and I like that better than compliant.
It's much better, but the non-compliance has that negative sort of barb to it. And what you said, that compassion fatigue. When we as clinicians give really good, solid advice about how to be well and feel better, and that same patient shows up over and over again, not following through, all of a sudden we go from compassionate non-adherence to the kind of snarky non-compliant description.
You know, I did a recent patient with a hemoglobin A1C 11 and did the diabetes distress on him. Had a really good conversation, enlightened me tremendously. And then 2 days later, my medical assistant told me that that patient said, finally, Dr. Shahady understands me. And before that, I thought we had a great relationship. Of course, his hemoglobin A1C wasn't where it was, where it needed to be. So I'm sure you find the same thing once you get, it enhances the relationship and the understanding.
Absolutely. So funny, this afternoon when I was walking over to meet with you, there was a gentleman on the elevator, and he turned to me and said, oh, you're dressed like you're going to a conference. I said, actually, I am. And so we had this nice conversation, and he said, oh, so you're talking about diabetes? And I said, yes, I am. I said, actually, I'm a type 1. And then he confides and says, I'm a type 2, and it's horrible. And I said, I'm so sorry. And this was his final comment. He said, I so wish I could find a provider who would talk to me in a reasonable way and listen to me. And it was just so beautiful because there's my whole talk. We as providers have to connect. They have to feel like and believe that they're the patient's the most important thing. And we're hearing everything they're telling us.
You know, we're both fans of Dr. Fisher and Dr. Polanski, who created this. What do we do about it? So I find someone is having issues like provider issues or emotional issues with the family. So any tricks on how I address that besides sending them to you?
Well, and this morning we talked about, you know, one of those worries about diabetes, one of those buckets of diabetes distress is access to care. What if I live in a very rural area as a patient and I don't have a car? And the closest of you or any healthcare provider is 50 miles away. All of a sudden, I'm very limited. So one of the things that we talked about last year, we'll talk about again this year, other ways to provide those services. Those are CBT, cognitive behavioral therapy, as well as mindfulness-based programs are all available online. Very affordable. So no matter where you live, or if you're restricted to home, you have access. And also, there are a ton of very good smartphone apps. So as long as we have patients who are smartphone savvy, then we can certainly use those skills.
Do you want to mention some of those?
Oh, sure. Let me see if I can just from memory recall a couple. So there is a mindfulness-based program called stopbreathethink.org. So you can go to their website, but also the App Store. You can search it that way. It is
Say that again.
Stopbreathethink.org.
Okay.
Simple. We love the fact that it's free. Patients love it. There are guided meditations. They're very short. Some as short as 3 minutes up to 8 minutes. And we know from the data that with mindfulness interventions, we see neurobiological changes with as little as meditative practice 3 times a week for 20 minutes each time. So an hour a week. So sometimes when people hear these recommendations about mindfulness, they sometimes think, well, I don't have 2-3 hours a day to meditate. We don't need that to really get the benefit. So that CBT exercise, fabulous. The effect size in terms of effectiveness in treating depression. So we could push that to diabetes and distress. A great intervention. As clinicians, we just have to be really clear. What does that mean? How many times a week? The intensity, the duration.
All right, well, if I was a busy primary care clinician, maybe they're going to, the questionnaire is going to be done by their medical assistant, so I get it back. And I see the score is high. And there's, you know, I'm sure you're going to talk about what means moderate distress, what means severe distress, and there are numbers with that. What do I do? You know, in my short period of time, what do I do? What's some trick? Because I'm not as talented as you are in all those areas.
Time is the issue.
Time
is really the issue. So the thing that I recommended last year, and I recommend this really no matter where I'm speaking, because all clinicians, primary care or even mental health specialties, we just don't have that luxury of unlimited time. So I always recommend create a one-page flyer. It only takes one time, maybe an hour to create it. And list those resources, maybe online programs, a couple of apps. If you live in a larger city where you have access to a lot of providers like me, you might list a couple of names of referral sources. so that then you don't have to spend the time to itemize each and every one.
Right.
Exercises as an example. Very clearly for depression, 30 minutes a day of a brisk walk at about 4 miles per hour.
Right.
So we want 14 miles a week.
Right.
Never tell the patient that because they'll be thinking, I can't do 14 miles anytime. So we break it down. That's 2 miles a day at 4 miles an hour.
Right.
And if you don't want to tell them 4 miles an hour, brisk.
Right.
And that, write it out on a prescription pad.
Excellent.
Specific. Very different than me just saying, you really should exercise. It's very good for you.
Probably you don't use the word exercise, but physical activity, right?
There you go.
Yeah.
Get out and move.
All right, very good. Well, this is wonderful. Just let me mention the website I mentioned to you, and you could just Google Diabetes Distress Learning Center, and it'll take you to a website which is free, and it has the, they can obtain the distress questionnaires, the 2-question and the 17 one, and then some of Dr. Fisher's articles where he discusses ways to do it. So for that, in addition to what you're saying, but thank you for being here.
Thank you for being so much. It was a pleasure.
Yes, ma'am.